Hello, good afternoon, good Friday afternoon. Thank you for joining the iBEST visiting series. My name is hypertension. I'm the lead for, biomaterial, tissue organ and repair theme at the iBEST. And now today, it is really my great pleasure to have our well-known cardiologist, Professor John Cockcroft, visiting here and give a lecture. And Professor Cockcroft is a professor of cardiology at the Heart Research Institute in Cardiff. And also now he holds the position of a special professor of cardiovascular disease prevention at the University of Nottingham. And now he's currently a visiting professor at the Columbia University. And interestingly, he's very dominant cardiologist, and also he's very, a leading professor, leading field expert in bioengineering. Combine his medical background with, bioengineering, the technique, and moving, the medical instrument and also measurement and those kind of technique to the very, very different levels. So Professor Cockcroft has developed a simple, non-invasive, operator-independent and validated technique to assess central aortic pressure. That might be very, very future, for our near future for the clinical monitoring and the measurement treating patient and following the intervention. And today, so he will give us a talk. It's very interesting. Are we still living in the past? And the measurement and the treatment of blood pressure in the hypertension clinic of the future. Thank you very much, John.
Well, thank you very, very much for that kind introduction. I have to tell you that I've been in Toronto since Tuesday, and I've been dying to give this lecture all week. And you couldn't have chosen a better place for me to give this lecture, because I am a visiting professor in the Department of Biomedical Engineering at Macquarie University in Sydney. And I have to tell you that you guys are not living in the past. The problem is that clinicians are living in the past. There's a big gap between what you guys do, which is 21st century, and what we do, which is Stone Age. So I'm going to tell you what I think the future is. And if you don't go home as biomedical engineers smiling and saying, yes, we knew that, then I failed. So we're just going to start with a little quiz because it's Friday afternoon. So here we have self-driving car, fixing the US elections. The Opal card, which I use in Sydney, this is a great card because unlike most transport cards where you tap in and you pay for the same for one journey as you do for 20 stops, with this card, it's very smart. You tap in, and when you tap out, it charges you only for the distance you've been. And finally, this is the measurement, the cuff-based measurement of blood pressure. So what do you think is the odd one out of these four? Correct. It is the cuff. And the reason it's the cuff is that all the others involve artificial intelligence. And you guys know how much artificial intelligence is already incorporated into modern life. But despite this, artificial intelligence has very late come to medicine. Despite the fact that you biomedical engineers have tried to get it into clinical practice, it's come very late to the party. So what about the history of blood pressure? Well, we know that although we could measure blood pressure in the early 1900s, nobody did it until the insurance companies said, well, we know it's predictive of heart attack and stroke, so we want it measured. And the doctor said, why should we measure it? And the insurance companies said, if you don't measure it, we won't pay you. And strangely, it got adopted into clinical practice almost overnight. And we know that blood pressure measured using the old-fashioned cuff that I've showed you is predictive of stroke. And this is data from over 1 million people, systolic and diastolic pressure. And you can see there's a big relationship between blood pressure and stroke. It's steepest in young people, but it's also there in older people. And exactly the same for myocardial infarction, for heart attack, a relationship between systolic and diastolic pressure and heart attack. And we also know that if you reduce blood pressure, you will reduce stroke and you will reduce coronary heart disease. So far, so good. Quite a big success story. Over the following years, we've had a new drug to treat hypertension almost every decade. So we started with sympathetic blockers and thiazide diuretics. And the reason we started with sympathetic blockers and thiazide diuretics is that they targeted the physiological systems that we knew were involved in regulating normal pressure. We then went on to beta blockers in the 60s, calcium channel blockers, ACE inhibitors, angiotensin II receptor blockers, and finally in the 2000 direct renin inhibitors. So we've got a number of different classes of antihypertensive agents. And we know that despite people saying that the more modern agents would be better, we know that there's really no difference or no apparent difference between any of these agents, provided they lower blood pressure. So you don't appear to get benefit beyond the benefit you get from lowering blood pressure. But why you give a patient one drug or another, that is what is most important, as we're going to come on to. Well, 50 years ago, cardiologists were standing in cardiac catheter laboratories, and they had invasive pressure lines both in the arm and in the aorta. And they noticed that in a lot of patients, particularly in younger patients, that there was a big difference in the pressure between the arm and the aorta. And they said, well, this is, and particularly in young people, and they said, well, this is very, very interesting indeed, which of course it was. But they then said, well, you know, there's really not a lot of money involved, so they forgot all about it. And in the 1990s, it was revisited. This is data from Alberto Pauca, who's an anaesthetist. And it's looking here, the vertical axis is pressure in the radial artery against pressure in the aorta. And you can see here that if you look at diastolic pressure, there's very little difference between the arm and the aorta. If you look at mean pressure, again, there's very little difference between the arm and the aorta. But if you look at systolic pressure, just like they'd shown 50 years previously, there was big differences in systolic pressure between the arm and the aorta. Very big differences. And the reason that I'm teaching people who already know this here, the reason that you get the difference is that pressure gets amplified as you go away from the heart towards the periphery, towards the brachial artery, and blood doesn't flow uphill, so you get a reduction in mean pressure of 2 millimeters of mercury, but you amplify the systolic pressure going from the aorta to the arm. And that amplification is due to the fact that the arteries are elastic. So why do we have elastic arteries? Well, for biomechanical reasons, to be perfectly honest, because your left ventricle is ejecting blood intermittently at very high pressure, and you do not want your microvessels in the kidney or in the brain or in the eye to see big changes in pulsatile pressure and flow. So those changes due to ventricular ejection are buffered out by having an elastic aorta. It takes up that pressure and then gradually releases it. And so that reduces changes in peak pressure, it maintains diastolic pressure, and it smooths blood flow and improves efficiency. And when we get older, we lose that buffering capacity because the aorta becomes stiffer for a number of reasons, but in all of us, the elastin is going to break down and fragment, and you're going to get much more collagen deposited, resulting in loss of elasticity and increased stiffness. And when you get that, you can't buffer those hemodynamic changes due to ventricular ejection to the same degree. So you get a rise in systolic pressure, a decrease in diastolic pressure, and that leads to systolic hypertension, heart failure, myocardial ischemia. You get changes in shear stress leading to decreased nitric oxide production, increased cyclical stress, which leads to further arterial remodeling and further increases in arterial stiffness. And all of this increases your risk of a cardiovascular event. So I shouldn't really show you guys the next slide because you're biomedical engineers. But for the people who may not be biomedical engineers in the audience, this is a cartoon showing you ventricular vascular interaction. And all of you knew about this when you were children because none of us would admit it, but we all played a game where we sat in the bath, we slid forward, produced a wave, hit the end of the bath and came back and splashed all over us. And then we worked out that if we slid forward harder and faster, we produced a bigger wave, hit the end of the bath sooner and came back and splashed over the whole room. So all of us understood this interaction. So when you've got a nice elastic aorta, that forward going wave due to ventricular ejection is reflected back from a lot of reflectance sites in the periphery so that it arrives back in diastole, and that's when you get coronary artery filling, coronary artery blood flow. So when you're young with an elastic aorta, you've got a very good ventricular vascular interaction leading to an increased coronary blood flow during diastole. So whoever made us did a very good job. It was a good design. But unfortunately, particularly as most societies are living longer, when you live longer, your artery becomes stiffer just because the elastin will wear out, fragment, and you get increased collagen. So when you do that, your aorta can't buffer out those forward-going waves, and they hit the reflectance site sooner and come back not into diastole anymore, but in systole when the aortic valve is still open. So you get an extra rise in central blood pressure due to wave reflection. So now you've got ventricular vascular mismatch, and that reflected wave is augmenting central systolic pressure. That increases your vascular afterload and your risk of developing left ventricular hypertrophy. It decreases coronary perfusion because you've shifted that reflected wave from diastole into systole. It increases myocardial oxygen demand and subendocardial ischemia. It increases flow turbulence and endothelial dysfunction and atherogenesis. And it increases pulsatile strain and the chance of plaque rupture. And even if you haven't got any equipment to help you look at this interaction, you can get a handle on it by looking at their pulse pressure. So subtracting their diastolic from their systolic pressure, their pulse pressure is a pretty good surrogate marker for a loss of elasticity in the aorta. And not surprisingly, because of this, a load of systems have been designed to perform pulse wave analysis, to look at this interaction between the heart and the blood vessels. And most of them, or the early ones, use the same basic technique. There was an invasive recording of a pressure wave, so you have to do it in an artery that's accessible, the carotid, the radial, or the femoral. You then subject that waveform to mathematical analysis, and that usually involves breaking the waveform into harmonics and subjecting it to Fourier analysis using a generalized transfer function. And when you do that, you can measure central pressure in the aorta or the carotid artery. You can look at that wave reflection and you can express that secondary rise in central systolic pressure due to wave reflection as the augmentation index. And you can measure arterial stiffness in the form of arterial pulse wave velocity by gating the signal between a carotid measurement and a femoral measurement to the ECG, measuring the distance between them, and you'll then know how fast that pulse wave is traveling down the aorta. So fast transit time, a high pulse wave velocity, a stiff vessel. And this is one of the early systems here, the sphygmocore system. Here is the tonometer on the radial artery recording the waveform, and this is the central aortic waveform generated completely non-invasively. Here is the first pressure peak, P1, due to ventricular ejection. Here is this second peak due to wave reflection. You can record it as augmentation pressure or augmentation pressure over the pulse pressure as a ratio, the augmentation index. And as I said before, if you gate the signal to the ECG, you can measure carotid femoral pulse wave velocity as a measure of aortic stiffness. So already you can see that it's very easy to measure a large number of hemodynamic parameters completely independently of cuff blood pressure. And as I already showed you at the beginning of the talk, there are already big differences because of amplification between pressure in the arm and pressure in the aorta. And of course, your heart and your brain and your kidneys never see the pressure in the arm, they see the pressure in your aorta. And unless I've missed a New England Journal paper, I've seen lots of heart attacks. I've never seen an arm attack. So carotid femoral pulse wave velocity is, to this day, considered, in terms of non-invasive assessment, the gold standard to assess arterial stiffness. And there is a large number of techniques now available non-invasively to assess aortic pulse wave velocity. I just mention here in the bottom right MRI, because if you use carotid femoral, the aorta is quite a long vessel. If you use carotid femoral pulse wave velocity, you assume that the aorta is homogeneous and stiffens at the same rate. That's not true. So if you use MRI, you can look at regional changes in stiffness, so probably more accurate. If you look at pulse wave velocity, arterial stiffness as a predictor of cardiovascular events, it's been shown to be a strong independent predictor, independent of other risk factors, both of total cardiovascular events, cardiovascular mortality, and all-cause mortality. This is our own study. This is individual patient data from nearly 18,000 subjects, and using pulse wave velocity, you can actually reclassify people at intermediate risk either into a higher or a lower risk tertile, and this is very useful. Now, a lot of risk factors outside of the Framingham risk score have been proposed that we should measure. But this is a very important study from the New England Journal, and it's looking here at death in the left-hand panel and major cardiovascular events in the right-hand panel, and it's looking at the Framingham risk equation with and without these extra biomarkers. So things like CRP, albumin-creatinine ratio, AMP. So whether you look at the risk with or without the biomarkers, it has absolutely no effect on the Framingham risk equation. So it's pointless to measure them because they're giving you no better improvement in risk than just using the standard Framingham risk equation. But if you add in pulse wave velocity, as been done in these two studies, you can shift the Framingham risk equation. You can give extra risk production. Here is the risk attributed pulse wave velocity. Here's the Framingham risk score. If you add pulse wave velocity to the Framingham risk score, you do shift that ROC curve. And again, in this other study, again, you can see that adding pulse wave velocity gives you extra predictive value. So this is an independent predictor of cardiovascular risk. And the reason that it's an independent predictor of cardiovascular risk is shown really in this cartoon here. Here are some of the Framingham risk factors: blood pressure, glycemia, and lipids. If you measure them over a lifespan, they will go up and down. They won't be the same every time you measure them. But if you look at arterial stiffness, it's going up here as you get older. And that's because it is like hemoglobin A1C for your aorta, for your large vessels. And what it's telling you is the number of risk factors, known and unknown, that you've been exposed to, and the length of time you've been exposed to them, which is why aortic stiffness is so important as a risk predictor. And one of the reasons, as I've shown you, is that when you've got a stiff aorta, as you as biomedical engineers know, it's producing a lot of hemodynamic changes, and they are not good hemodynamic changes. So we've moved now from tonometry to cuff-based devices for looking at central pressure, augmentation index, and pulse wave velocity. And this is because if we're going to get these techniques into clinical practice, they have to be suitable to be used in GP surgeries by nurses and doctors. And this is one such system, the mobilograph system. This is from Germany. This company had 25 years experience in using a system to look at ambulatory blood pressure over a 24-hour period. And they realized that things like central pressure and pulse wave velocity were going to be important. So they went into collaboration with the Austrian Institute of Technology, and they developed a generalized transfer function, which they called the arc solver. And basically, rather than using the carotid, the radial, or the femoral waveform, they used the brachial waveform. And in exactly the same way, they subjected the brachial waveform to harmonic breakdown Fourier analysis. And again, they generated non-invasively the central aortic waveform. And like the sphygmocor system, they validated invasively with invasive aortic pressure measurements. And here is a trace of a 24-hour monitor from the mobilograph system. And what you can see that's interesting here is that if you look at peripheral and central pressure here in the yellow, sometimes the amplification between the aorta and the arm is not very much. In other times, it's a lot. What this absolutely means, we really don't know yet, because this is the first time that we've really been able to make these measurements. So we thought that this was a really interesting development, because it was making central blood pressure estimation moving closer to be used in clinical populations. But we made the point that you really have to validate these systems invasively. So Albert Alvolio at Macquarie and his colleagues looked at a number of ambulatory devices for measuring central aortic blood pressure and arterial stiffness. And their overall conclusion was that in general, these were reasonably reliable, although in the case of some of the systems, you had to tighten up a little bit. So that's kind of where we were and where we are now. But what about the future? So I'm going to tell you what my view of the future is. So Niels Bohr said, it's very difficult making predictions, especially about the future. So I'm crazy enough to risk making some predictions to you here today of what I think the future is going to be. And I'll tell you now that you guys are going to be crucial to this future. You've already contributed enormously, as I'm going to show you in a minute. What you need to do is drag the clinicians kicking and screaming into the 21st century. Please do it. So, artificial intelligence. Hopefully many of you will have watched 2001. It's an iconic film. So this is where we are at the moment in a hypertension clinic. We are prehistoric, as I'm going to show you and why. And this is where we're going to go, hopefully, although hopefully, unlike Hal, who of course, you know, went completely out of control, we've got to be very careful, because although artificial intelligence holds out a future that's going to really make treating hypertension really personalized to individual patients, we need to be very careful, because just like the internet can do a lot of good, it can also do a lot of bad. And we know that artificial intelligence is already bad. It's put Donald Trump in the White House. And it may even keep Donald Trump in the White House. So we've talked about cuff-based blood pressure measurement, and we've talked about systems that measure over a 24-hour period. But if you talk to patients, they don't like wearing a cuff for 24 hours, and about 20% of them won't wear it because it keeps them awake at night, and they don't want to wear it. So the next obvious development is cuffless blood pressure measurement. You guys know that, you guys knew that, and you guys made very big contributions to cuff-based or cuffless methods of blood pressure telemonitoring. So one of the things that you do that's probably quite bad is that you keep Jeff Bezos in business, and you allow Jeff Bezos to give his ex-wife $38 billion. If you allow him to make her the richest woman in the world. And when you think about it, Jeff Bezos has to be quite clever, because he never makes anything, and yet he's the richest man in the world. But he sells a lot of stuff. And this is just a snapshot of what's available in an Amazon warehouse near you. And these are all cuffless systems for measuring blood pressure. And you can see that they vary in price between $90 and $16.99. Are any of them validated? Of course not. Do they sell? Of course they sell. That's why Bezos is a billionaire. So this is already happening, and we don't want this to get out of control and people think that they're buying something that's useful. So basically, as you know, pulse detection, you can either use pulse transit time, and pulse transit time, you can either use applanation tonometry, which is the sphygmocor system that I've already showed you, which is a strain-based measurement, and it's directly related to the pressure in the large arteries, or you can use photoplethysmography, which is a volume-based measurement, and Phil Hovyenchik in St Thomas's in London has done a lot of experiments with photoplethysmography. And it's volume-based related to hemodynamic change in the vascular beds of the microcirculation. Or you can use pulse transit time with bioimpedance or sensors on mobile devices. And you know that sensor technology is incredibly advanced now. This isn't the problem, the accuracy of the sensors. So most of these devices that Jeff Bezos will sell you are based on the ECG and one pulse. So they're really measuring pulse arrival time rather than pulse transit time. And I don't know what you guys in the audience think, but the money at the moment is that probably pulse transit time is probably a little bit more accurate than pulse arrival time. And so people are trying to develop better technologies based on measuring pulse transit time. And if you look at recent research into developing trends of wearable sensors, there's been a huge increase in research. This is a system that was very interesting that I was kind of involved in. It involves a Danish company, and basically they had a cuffless system which was a patch that you put on the arm, and it used electrical bioimpedance to get a handle on brachial distensibility and then back calculating to get systolic and diastolic blood pressure. So here are is the electrical stimulation. The nurse puts it on, you go home, you can wear it in the shower, you come back the next day, the nurse takes the little card out of it, throws the patch away, puts the card into a reader and reads your 24-hour blood pressure. But of course, you can actually, this actually gives you a waveform. So one of the things we were trying to do with them is analyze this waveform and get central pressure over 24 hours and indeed maybe even pulse wave velocity. Now, unfortunately, this started off by being funded by some Danish venture capitalists who put $1 million into this scheme, but they thought that this was going to be like Uber or Google or Facebook or whatever, Snapchat, whatever anyone's on now. And they were very disappointed that at the end of the year, they weren't rolling in money. So they didn't fund it anymore. So the guy who was driving this, Lars Ladding, has sold his intellectual property to a company in San Diego who are taking this forward. So this may yet appear in the clinical arena. This is even hotter. This is using conformational change using an ultrasonic device. So you can put this virtually anywhere on the body and you will get a measure of blood pressure here in a waveform. And if you compare to conventional commercially available tonometers, it looks to be very good. So you guys are just right up there ahead of the field. This is even ballistocardiography. You can get up in the morning, your scales will tell you you're fat, but they'll also tell you that your pulse wave velocity is not too bad. And they're using, it's a weighing scale-based pulse transit time. This is an iPhone application to measure your blood pressure via an oscillometric finger press method. This is something that Accor are developing, which is radar technology based around the radial artery. And why not only have you guys made big contributions, but you know, you guys are potentially going to be rich, very rich, because this is the Apple Watch, which has now just got it's now got class 2 recognition from the FDA to detect atrial fibrillation. So you wear this and Siri says, "Good morning, John. Did you know that your heart rate is irregular? You should go to see your doctor." So it's been approved by the FDA. If you haven't got this book, I've got it with me in my bag, you need to go to your librarians and say, we want to order this book on Monday, because this book covers in much more detail what I've already been talking to you about in terms of the techniques for measuring pulse wave velocity, pulse arrival time, pulse transit time, machine learning techniques, design of clinical trials. It covers all of this in great detail using really acknowledged experts in the field. And it's actually very well written. I wouldn't try and read it in big chunks, but a chapter at a time, it's incredibly useful. And of course, you guys will understand it. If you gave this to a clinician, it's like you're giving them a book in Chinese. So I apologize in advance if I'm talking down to you. So we've talked about cuffless blood pressure, but what about contactless blood pressure measurement? Well, it's very good that I'm speaking in Toronto, because this is Kang Lee's smartphone-based device that will measure your blood pressure by transdermal optical imaging and looking at pulsatility in the face. Now, is Kang in the audience? Oh, it's there. Yeah, well, Kang, he and I last night, this is very, very interesting. So Kang and I last night both admitted that we would rather have a paper in the New Yorker than Nature. So there was a competition on, but what Kang doesn't know is that he is actually in this week's New Yorker. And I'll show you later. You're not in there by name, Kang, but you're in an article which is about Yuval Harari, the Israeli author who predicts the future. And he refers to your face recognition technology, and he refers to it not in a very positive way, I have to say, Kang, because it is true that artificial intelligence can be misused. And he says that in a dysmorphic future, they will misuse it, because what will happen is they will look at what happens to people's blood pressure when they hear Donald Trump, and if they hear a Democrat, and if their blood pressure goes up, they'll be classed as a dissident. So be very careful, and I'll show you. You need to photograph it and put it. So you need to be very careful that Trump doesn't deport you as a dissident. So I mean, if Donald Trump reads the New Yorker, you're in trouble, because he'll say, "Who is this guy?" So as you know, I only met Kang last year, and he already not only fired me up, but he fired up clinicians in Columbia and Cornell in New York, who, unlike the prehistoric doctors that I've referred to, are prepared to embrace the future. So you identify a number of areas on the face here, and you can get very nice signals. So this is kind of the future of blood pressure monitoring. You're going to be using cuffless techniques, sending all the data to the cloud. You will then use that data, subject it to deep learning, artificial intelligence, which will then allow you to better predict and treat blood pressure. So this is why we are still prehistoric. These are two papers from the Lancet, and they're talking about the accuracy of cuff-based blood pressure. You have to be joking. You have to be kidding me that in 2020, they're saying how accurate is a 100-year-old prehistoric system. These people should be committed to a mental institution. This is madness. Or as I said at a meeting in Brisbane, and I'll be polite, this is intellectual self-pleasuring. You know what I mean. So let's talk phenotype now. And phenotype is something that molecular biologists can't spell. So what is the phenotype of blood pressure? Well, the phenotype of blood pressure is cuff-based measurement of blood pressure in the arm. That is the phenotype of blood pressure in 2020. So that's like saying that your phenotype is you've got an X and a Y chromosome, and Zhongping's phenotype is she's got 2 X chromosomes. That's as much detail as we're getting on the phenotype of hypertension. So you see that maybe some of my colleagues are in Jurassic Park. This is complete stupidity, as all of you know. So what we need to do is redefine the phenotype of hypertension, and we can do that. So the phenotype of hypertension used in the guidelines has been systolic and diastolic pressure measured in the brachial artery, and despite evidence that pulse pressure is a better predictor in the elderly, pulse pressure isn't even in the guidelines. And you don't need an artificial intelligence algorithm to subtract diastolic from systolic pressure to get pulse pressure. This is how bad we are. And we know that despite similar measures of systolic and diastolic pressure, individuals can have extremely different hemodynamic profiles in terms of cardiac output, pulse wave velocity, central systolic blood pressure, peripheral resistance, and wave reflection, etc. And moreover, these parameters are influenced by age, ethnicity, and body mass index. So there is a whole load of hemodynamic parameters that we can measure non-invasively thanks to you guys. So give yourself one pat on the back already. We can measure these things. And are we using them? No. This is why you need to drag us into the 21st century. So there's been a huge effort expending on trying to define the genotype of hypertension, billions of dollars. And they do that in order to personalize treatment, to better target treatment to an individual's genotype. But that's nonsense, because despite that, they're still using a phenotype of systolic and diastolic pressure in the brachial artery. And this approach ignores other simply measured hemodynamic parameters. And as I said, we've got a load of increasingly operator-independent, cuff-based, non-cuff-based systems that will help us to hemodynamically profile these patients. And most importantly, I showed you that we've got about 10 different classes of antihypertensive agent. We know that those antihypertensive agents have different effects on hemodynamics. So although earlier on I showed you that there was no difference in outcome between any of them when you looked at the trials, that doesn't mean that there isn't. It's just that maybe they were giving the wrong drug to some people for their hemodynamic profile, and sometimes they were getting it right by accident. So this is some of our own work from the Enigma study in young people. And this actually shows that there's a difference in the cardiovascular phenotype of elevated blood pressure based on the Y chromosome. So men and women are different in terms of their cardiac output, their heart rate, their systemic vascular resistance, and their stroke volume and their peripheral vascular resistance. So there's already differences. So a drug that might be good for a woman might not be so good for a man. We know that if you are fat, there's differences. So the underlying mechanisms of elevated blood pressure differ with adiposity. This is from our own Enigma study. And this is to show you that the antihypertensive drugs have different effects on central pressure, aortic pulse wave velocity, and wave reflection. So here is the ACE inhibitors. So if you had aortic stiffness, you wouldn't be giving diuretics or necessarily a nitrate. If you had a high augmentation index, you might be giving nitrates, which would lower that. But the main point is that these drugs have different effects. So you don't have to be a rocket scientist to know that what you should be doing is giving the appropriate drug to a patient's hemodynamic profile, which you guys can measure very accurately. So the weak link is not you guys. Look what you guys have done already. It's fantastic. What have we done? We've gone back into our caves and hit bones. And this is looking again at a panel, this is looking at a panel of different classes of antihypertensive agent and central blood pressure, augmentation index, pulse wave velocity, etc. These drugs have different effects. This is very, very interesting because this is a paper that I reviewed recently and we've written an editorial to it. But basically, if you look at the diagnosis of coronary artery disease, then it's very difficult to diagnose coronary artery disease. And even if you look at coronary angiography, so there's a paper in the New England Journal where they looked at 1 million coronary angiograms. And out of 1 million coronary angiograms, 300,000 were normal. Cardiologists didn't mind because they still got paid, but they were normal. And that's exposing a patient to unnecessary risk and very expensive. So what Michel Safar and his colleagues did is that they developed what they called the pulse wave velocity index. And this was very simple because there is a large amount of published data, including data from the European group, that will tell you what a normal pulse wave velocity is for your age and mean blood pressure. So they used this and they developed a very simple way of calculating the pulse wave velocity index. And they'd already looked at this in people with end-stage renal failure, and they'd looked at survival. So if you had a negative pulse wave velocity index, you did pretty well, you stayed alive. If you had a positive one, then you fared much worse. So they then applied this to people who were undergoing coronary angiography. And if you had a negative pulse wave velocity index, the coronary angiograms were normal. If you had a slightly positive pulse wave velocity index, you did have coronary disease, but it was non-obstructive. But if you had a high pulse wave velocity index, then you had coronary disease and it was obstructive. So this was a very simple AI machine learning algorithm. You know, this is something that your students would have been able to do, and yet it was making a very important clinical impact. We've just finished the study where we're looking at the effect of genetics on response to antihypertensive drugs. So this is very interesting because we genotype all these patients. We ask them to self-classify themselves as white Caucasian, black Afro-Caribbean, South Asian, which they do. But when we genotype them, it's quite interesting. So some of the Afro-Caribbeans aren't as quite Afro-Caribbean as they think they are, and some of the Caucasians aren't quite as Caucasian as they think they are. We wouldn't, of course, be able to do this study in the States because no one would be genotyped in case they had 10% Mexican genes, and then Trump would kick them out of the country. So we're waiting for the results of this study, but when we've got the results of the study, this is the sort of information that you can put into an algorithm to help you define what drug is the best drug to give a patient. So artificial intelligence, I don't need to tell you, this is just data on publications. It's going up exponentially, and there's a lot more papers on artificial intelligence and blood pressure now. So now we're going to talk about the clinic of the future. This is Crazy John's. You want to come and see me in my hypertension clinic. So this is what's going to happen if you see me in my hypertension clinic. I'm going to be using a device, doesn't matter what it is, and I'm going to know the patient's cardiac output, their pulse wave velocity, their central pressure, their augmentation index, their amplification. I'll also hopefully have some data on pulsatility, and maybe I'll have all these parameters over a 24-hour period. Now, I've got to be very careful because I gave grand rounds at Yale last year, and it ended up with me having to go on to Donald Trump's Twitter feed, because I made the point that in my Crazy John clinic, nurses won't be weighing the patients because I can see they're fat. And as you know, as I pointed out, Donald Trump exaggerated his height so that his body mass index would appear more normal. And I said, well, I'm sorry, I can see Donald Trump is fat. And then I kind of, after the talk, I thought, maybe I made a big mistake, because if he found out, I would be getting some serious trolling from Donald Trump on his Twitter feed. Fortunately, I wasn't on. So I'm happy to be on your Twitter feed. So I don't think Donald Trump tunes into the iBEST Twitter feed. So basically, I'll be getting all these hemodynamic parameters thanks to you, thanks to all of you. You guys have done your job 10 out of 10. Have we done our job? Have we cocoa? So I, without a robot, would probably be able to make a stab at what would be the best drug for your hemodynamic profile. So if you had a very high pulse wave velocity, you're a Harvard rower, you've got a cardiac output of 10, and you've got systolic hypertension, even I could probably work out that you'd have a beta blocker. But I'm not going to do that. I'm going to use a robot. I'm going to use artificial intelligence, machine learning, which will then tell me what is the best drug out of the 10 categories of drugs that's best for that patient, based on their phenotype, which is easily measurable, not based on their peripheral blood pressure, one data point, and not based on whether they're Chinese, and not based on whether they're based on their individual hemodynamic fingerprint. Your hemodynamics are almost like a fingerprint. So you can have 10 people, they've all got the same cuff blood pressure, their hemodynamics are different. And if you have a relative that's seeing a doctor, or you're seeing a doctor, ask the doctor politely why the doctor is giving you that drug. And do you know why the doctor's giving you that drug? He's giving you that drug based on drug company studies, not individual data. He's giving you that drug based on guidelines that he probably hasn't even read. He's giving you that drug because a very nice drug rep took him out to dinner. He's not giving you the drug because of your hemodynamics. And it's going to revolutionize clinical trials. It's no longer going to be drug X versus control. We're now going to be able to use wearable and contactless technology, and we're going to be able to use biobank data, multi-omics genetics, adaptive trial methodology to much better perform clinical trials using artificial intelligence. Robots do not have emotions. They're not interested in what their H index is. They don't get taken out to dinner. They're not, you can't bribe a robot, but they're able to process vast amounts of information. I don't think GPs are a little bit like, Carter. They can't chew gum and walk at the same time. It's very difficult for GPs to process any information. And the more you give them, the better they get. The older we get, the worse we get. I show this especially for John Flores in the audience here, because he and I are interested in drugs to treat pregnant women and drugs to treat pregnant women based on the hemodynamics of pregnancy. So pregnancy for a woman is like exercising 24/7. So this is the Bavarian telemedicine project, John. I've been given these slides. This data isn't published yet, but I've been allowed to use them. So basically, they used the mobilograph system in these people. So they were able to monitor things like pulse wave velocity, central pressure, etc., over 24-hour periods. And this is just early data. This isn't treatment data yet, but basically, if you look at the telemedicine group that used a lot of these parameters other than just cuff blood pressure, then the birth weight of their infants was significantly higher than the control group. Only 3 infants in the telemedicine group needed intensive care as opposed to 13 in the control group. And there was no preeclampsia, so there was no eclampsia in the telemedicine group, but 2 in the control group, and they had less cesarean section. So already it's making a contribution. And I was at the International Working Group on Maternal Hemodynamics in Belgium last week, and data was presented by Mark Spanderman, where they hadn't used an algorithm, but they had deliberately tried to target the drug treatment in these women to their hemodynamic abnormality. And if you measure it, they have differences in cardiac output, they have differences in peripheral resistance and augmentation index, etc. So I put this in specially for you, John. So what about humans versus robots? Well, you know, everyone said, well, a robot could never beat a chess grandmaster. And so they put a robot up against a chess grandmaster, and what happened? The robot won. And Go is supposed to be the most complicated game in the world, and of course a robot could never beat a human at Go. It did. So what are the trials that we should be doing? So you could have the robot, and the robot has cuffless technology, and the robot can measure cardiac output, vascular resistance, pulse wave velocity, central pressure, and augmentation index, and hopefully over a 24-hour period. So that's what the robot's got. The GP has got a 100-year-old piece of technology. He can do systolic, diastolic, pulse pressure if he can do simple subtraction, and maybe 24-hour blood pressure. So I'm wondering who's going to win this contest? Well, nobody in this audience would disagree that the robot's going to win this, hands down. So what if we make things easier for the GP or better for the GP? So we'll give the GP now exactly the same as the robot. So they've both got cuffless technology. They've both got these new hemodynamic parameters. So they're head to head with the same available information. And I'm sorry, but the robot's going to win this one as well. And the GP is going to say, what's central blood pressure? So let's see if we can put a robot against a robot, because you guys know that that's exactly what's going to happen. You know, you guys are going to be employed by, one of you is going to be employed by company X to help their robots. Another one's going to be employed by company Y. And you guys are going to be like Harvard mathematicians were to hedge funds. They're going to want you big time, and you're going to be able to name your price. So robot versus robot. So you give the robot on the left, it's got artificial intelligence, and you're giving him cuff-based data with systolic, diastolic, pulse pressure, and 24-hour ABPM, but the opposing robot is going to have cuffless technology as well, but it's going to have all these extra parameters. So it's robot with the parameters, robot without the parameters. And again, the robot with the parameters is going to win. And this robot say, you've got to be kidding me. How would I fund some of these studies? And I think this is a very, very interesting area as well, because all of us in this audience, or most of these in the audience know, we can write a grant application which takes us 6 months and a lot of time and effort, and we submit it and it gets turned down. And then we see 6 months later that one of the reviewers who turned it down is doing it themselves. Yeah, we've all been there, and it's not funny, is it? Not funny. What you can do, and again, there's a very good New Yorker article about this, you can put it on a crowdfunding platform. And what you do is you have to put it in a form that the public can understand, and you put it out there on the platform. If you don't get any money, you've wasted not a lot of time and effort. If you make money, you make money. And the the New Yorker article, there was a researcher in San Francisco who was a very good researcher getting NIH grants. She put one on a crowdfunding program and she got $100,000. So you ain't got anything to lose. And crowdfunding is going to be very important. And you know what I'm going to say next is that if you really wanted to be successful at crowdfunding, you'd be using the robot that rigged the American election to focus your crowdfunding onto the individuals who were going to give you money. So this is coming. Crowdfunding is coming as well. So this is a review. Again, if you read this, it's very interesting. It's The Future of Hypertension by Victor Zhao, who's now the president of Stanford and a well-known researcher. And I won't really say much more to this, but he's saying that data science and artificial intelligence is going to be one of the core mechanisms of transforming hypertension, trying to take us out of the dark ages. Now, the Dutch are always ahead of the game. They have now set up a cardiovascular artificial intelligence network consortium. And what they've done that for is because they understand that artificial intelligence is a good method for analyzing and interpreting complex data. In contrast to other fields, little AI, as I said at the beginning of the talk, has been found in cardiovascular research. And they feel there's an urgent need to catalyze the uptake and update of artificial intelligence. And so they have started this consortium where they will input and secure all the data, store it securely, data processing, and then they will be using artificial intelligence algorithms. So how would you want to be treated? Would you want to be treated by the establishment that's going on drug company studies? And this is the guidelines committee when they were younger. Or would you want to be treated by a robot? Well, I'm sorry, but the robot for me wins every time. So this is our editorial to the Sapphire paper. This is the past, and this is the future. The robot will see you now. So thank you very, very much for having me here. It is just perfect that I was able to give this talk to people who hopefully understand where I'm coming from and understand how important you guys have already been. I'm going to give an unashamed advert now. One of the things I also do is I edit a journal called Artery Research. And I'm going to abuse editorial privilege, and I've told Atlantis that I'm going to have a special issue, and the special issue is going to be called Redefining the Phenotype of Hypertension. So if any of you want to submit articles based along the lines that I've been discussing now, then please do think about submitting them to this special issue. The good news is I can tell you, which is true, that this is an online open access journal. So any paper that's published, it'll appear on the Web of Science. You will then be able to click, one click on the Web of Science will take you to the Atlantis platform, and then one click will download any paper in PDF format. So you're the sort of people that I want to publish. If you've any idea how you can help me drag some of my colleagues into the 21st century, then please suggest it to me. So I have to say that I'm going to be very sad to leave Toronto tomorrow. I've had an absolutely fantastic time, and thank you for allowing me to finish exactly where I would have wanted to finish, in a biomedical engineering facility. So thank you for your contribution to the 21st century. I apologize that we have been so bad at using the data that you've allowed us to collect. Thank you very much.
That's really excellent, very fascinating. And I am sure we have a lot of questions from the audience. Yes, please.
Oh, fabulous. As you know, we've been working in this fighting the same battle for 40 years. And 40 years ago, when I was doing the first Ph.D. intra-arterial ambulatory monitoring studies, we would calibrate against the mercury filled manometer every 12 hours. And we would look at the treatment responsiveness of the fluid-filled catheters, the whole system, to make sure that we can get the right harmonics. So we were very disciplined when applying that. So not having an engineering background, I don't understand how you can calibrate against an absolute value and helpless device. How do you calibrate it?
I'm not the best person to ask that question to, but if you buy the book, then explain that in more detail. But calibration is an issue, because if you look at the waveforms, then, as you know, you can either calibrate against systolic and diastolic, or diastolic and mean. And if you look at outcome data, then calibrating against diastolic and mean in terms of the waveform analysis is actually better. But how do you calibrate your device?
In my case,
yeah.
So we have, unfortunately, we have this $20,000 for continuous blood pressure measurement.
Can you use the speaker?
So
Calibration is an important thing.
So in our case, we fortunately have this very expensive continuous blood pressure machine. So we waveform and against the force. This is one way to do this. But at the same time, we actually know models against the nurse measurements, which is the FDA's which is not in there. So you should have more Asian kind of standard. But I think you can calibrate the instrument that measures the central pressure. It will force you can learn against that using calculus or calculus.
Well, I guess that's my point. We can't calibrate against the nurse or against the blood pressure. We know that the diastolic data is fabricated, and we know that it's not accurate. And so I think that the whole field has to start with the essence of calibration against an absolute.
No, I take that point, but if you look at, you know, as I showed you, that the difference between peripheral and central diastolic is not much. The difference between central and peripheral mean is not much. So if you use diastolic and mean, not surprisingly, you better get a better calibration than using systolic, and diastolic for the reasons that you've said.
But the accelerometric devices don't measure diastolic pressure. They only measure systolic and they calculate diastolic. So that doesn't help. And it's a soluble problem. I'm just having difficulty wrestling with it where it is in 2020. How close we are to solving that issue.
Well, I can tell you that all the devices that we get from Amazon aren't calculated.
John, I think it's very, very interesting, and you look at the pressure, but but pressure is it's big matter. However, pressure is really the most important might be is flow, right? Because whatever pressure is, but you have enough flow. I don't care about the pressure. But perfusion is more important than pressure. So how do you address this? And by nowadays technique, looking at the flow.
But don't ask me how I address it. I go to Albert
to you.
You guys tell me how I should address it. This is and this is why we have a meeting every year called Archery, and we don't have parallel sessions. So the engineers, the biomedical engineers, have their sessions, and they try and teach us, and the biomedical engineers came to the clinical talks, and we kind of teach them. So I don't want to teach you biomedical engineering, and the people who first got into this were aeronautical engineers working in wind tunnels, and then the clinicians then thought, well, this is quite interesting if we apply this to the circulatory system. But this is why we need more collaboration between biomedical engineers, because you need to say to me, well, this is okay, John, but that's stupid. You need to do this. And I need to say to you, if you want to make money, the problem is not, and we can have the discussions about calibrations and accuracy. That's not the problem. The problem is that a human being with very little intelligence is giving you a drug on virtually no evidence at all. And it doesn't matter. You've got to have a drug at the end of the day, and I would want the best drug for me, wouldn't you? And you're not getting it. So that's why I need your help and a robot's help because I know that's what we need. I want you to tell me how we can get there.
Also, from the biological point of view, you use the PWV index, so that's involving the age, because the age is the constant.
No, I don't. That's right. The PWV index. They derived it because it's not influenced by age and blood pressure. That's the whole point. If you looked at the thing, if you read the paper, that's exactly the point. It's an index that isn't influenced by age and blood pressure.
Okay, that's good. Because age can be very
of course.
Yeah.
Go back to the question. What's your opinion about calibration? I thought if we could measure the aortic pressure and correlate with any other index, and then we can, as long as we have enough population of the subjects, then we can get the mean calculation of the device. Then we can use that device to many, like the general practice. So is this good enough or is it not? Because you can directly store a catheter to measure the central blood pressure.
We can also do A-line.
Yeah, so this is many. So if we do that, and I think that's a good calibration method. So any device will have this. There's no absolute calibration method.
I think the problem is
for any device.
But the problem is that you go to a range of individuals, they're going to be detecting the calibrate device against different arterial mechanics. So if you have an elderly person with a calcified cardiac artery, i.e. Lucifer sign, you may not be able to apply your data that were required on that individual.
So that is like the variations.
I don't mean that that be the limiting factor. It'll be all of the different rigidities of the arterial tree that occur with aging, hypertension, and other diseases that will prevent you, I think, from taking data from healthy individuals and saying, I can use that function and infer what the blood pressure is by countless times.
So I guess that is the next step. How many parameters we want to follow, how multiple parameters we want to put into the AI system.
I'm not about the role consultant.
Yeah.
No, you need to put in as many parameters as you can get, because the robot will say to you, are you trying to starve me to death? Why are you just giving me this small amount of data? I want terabytes of data. Bring it on.
So I think this is a good place to discuss this because we have a lot of animal models. So that can be used in health conditions and disease conditions. Those will be invasive monitoring. So that can be considered as a gold standard for your calibration. So if you have tens of millions, those kind of data, your data must be trusted more.
We can infer quadruped data and then apply that to bipeds.
Pardon me?
Can't apply quadruped data to bipeds.
I couldn't hear your question.
He's saying that you'd have quadruped data in animals and humans are bipeds.
Oh, but we have a lot of kind of patient data, patient study. Yeah.
We could use hospital administrators.
Yeah. Yeah, it's always everything's possible, right? If you really want to do this further, that's you have funding, everything is possible. Yeah.
We were talking about the animal experiments and then John this one. You have to say, okay, are you sure your animal model can be applicable to animal, and from animal model is applicable to human? Of course, we can't see the direct translation, but in general, we could use that as reference for future study. And that's what.
Yeah, when you have very complicated case, of course, human is much more complicated than animal models. But you can always have the normal calibration that shouldn't be a major issue. Any other questions on the floor? If not, I think thank you so much, John, for this excellent, really amazing talk. Really,